This one I made 45 years old female with BMI 36.7. She has type 2 diabetes for 5 years. Other than type 2 diabetes, she was healthy. Was started on diagnosis on January. After 2 years, glycoside was added because of uncontrolled diabetes. Then the glycoside was stopped a year before she came because of, again, uncontrolled diabetes, and 36 units of glargine was added. So now when she came to see you, she is on Januate and then on glargine 36 units. Her fasting blood sugar was 221 and her A1C was 9.8. What would you do? So you have 4 choices.
Yeah, more importantly, no one here would ever have treated this patient like this after our talk today, right? You're not going to be using SUs, DPP-4 inhibitors, and metformin. You're all going to switch over, right? Hands up. Everybody agrees.
شو يا شباب يلا.
Yeah, but unfortunately, you still see many of those patients in the clinic. Every one of us would see once in a while. Some of those patients will come to see you. So what would you do? Would you intensify the glargine dose? We heard the talk yesterday. We switch to Novomex because the glargine is not controlling. You add Pio, or you restore the glycoside because it shouldn't be. Let's say these are options.
Okay.
It's a yes, no.
Do you want to do a show of hands?
Yes, we want to show of hands. Exactly.
Who wants number 1? مين بده الخيار الأول يرفع إيده؟ Okay. الخيار الثاني. Number 2. Number 3. Good. And number 4. All right, they were listening. The rest don't want to join in.
So
Okay.
I could see half of the people didn't raise their hands, which means they're a little. We don't do anything bad to people here.
Maybe they have other options.
Yeah, so maybe there's some other options.
Any other suggestions, for example? Okay, that's another option, viable option. You're right.
So that, for those of you who didn't hear, the comment was very high BMI. Why not add a GLP-1 receptor agonist? I think Muhammad actually gave a pretty nice talk on that earlier.
Yeah, so I made this long time ago when GLP-1 were not that much common. But anyhow, so the treating physician decided to escalate the insulin dose. He said, we started on insulin, we'll continue on insulin. And you hear yesterday the talk is their fasting still high. He's on 36 units of glargine, so just keep giving insulin until you bring the sugar down and you'll get glucose control. He has increased the insulin dose by 4 units per week while monitoring the fasting glucose, and after 6 months, the patient is receiving 98 units of glargine, has gained 16 kilos. Fasting glucose really dropped to 148, and the A1C dropped to 7.8. So that seems that escalating the insulin dose did work, did improve the glucose control. But what would you do here? Now, came to see you after 6 months. Would you keep increasing insulin dose until you bring the sugar down to 110? After all, she's still not perfectly. The control was improved, but not perfectly controlled. There is still room to improve. You switch to Novomex, or you measure C-peptide, or you measure fructosamine. C-peptide. Why you don't? Okay. So why you measure C-peptide then? Right. And just a comment before that. Just from the clinical presentation, what a major problem that this patient is presenting. But regardless, make it. What about insulin sensitivity? Her insulin sensitivity. Right? Oh, she's responding. The fasting went down from 2 some. Oh, well, that's part of the insulin therapy. The comment I want to make, how many units of insulin this woman is taking? 98. How you judge that amount of insulin? And yet her fasting sugar is 148. So I hope nobody here has diabetes. How much your pancreas or mine is making a day to maintain normal glucose tolerance?
15 units.
How much?
15.
15?
A little low.
No, 35. 30 to 35.
15.
So your pancreas and mine, with 35 units of insulin over the day, we have normal glucose tolerance. This woman is receiving 98, almost threefold that amount, and her blood sugar is still high. What does that tell you?
Yeah, I just want to make one other point when you answer that question. Many years ago, we did a study where we took normal, healthy people and we put them on the Clinical Research Center and we infused insulin for 72 hours. And we raised the fasting insulin from 7 to 21. That's about what the fasting insulin is in a diabetic. And these were like young kids. We made them insulin resistant as diabetic patients. So when you give more and more doses of insulin, it's not only the weight gain and lipotoxicity that's making them insulin resistant. The hyperinsulinemia is making them more insulin resistant. So you keep chasing your tail. The more insulin resistant, you give more insulin, and it's a self-fulfilling prophecy. So the question is, once you get above 0.4 or 0.5 units per kilogram, or 35 or 40 units, okay, do you want to keep pushing the insulin? So Muhammad and I like you.
Yes, I agree with you, but that's exactly the point that we want to warn people here, is that because that's what, at least even you'll hear it oftentimes, definitely from companies that sell insulin, that keep intensifying insulin, keep increasing insulin intensification until you get the glucose on target. But here, if you keep doing that, at least in some patients, you start to work against yourself. And of course, you can keep intensifying insulin in this patient and bring the sugar down, but you're going into that vicious cycle, inducing more insulin resistance because of downregulation of the insulin receptor, because of weight gain, and then you start to run into the problem of hypoglycemia.
You know, the ADA algorithm, if you look at the 2022 standards of care, if you don't have renal disease or kidney or cardiovascular disease, it says you can use any drug. First drug in the line, sulfonylureas, which I disagree with. Then DPP-4 inhibitors and insulin after metformin. In my opinion, insulin is not a good second choice after metformin for all of the reasons that Muhammad and I have been talking about. There are many other better choices. And the surprising, Muhammad, if you think back, Muhammad showed this study from the GRADE study. And remember, in the GRADE study, these are people who are on metformin, and then they were going to add a drug, and the idea was, what was the best drug to be added? If you added a sulfonylurea, remember, you came down and you failed. If you had a DPP-4 inhibitor, you came down and you failed. If you had an insulin, you came down and you failed. And I think the surprising thing to both Muhammad and I, and I'm going to let Muhammad, because he and I have talked about this, was the liraglutide came down and then you failed. So Muhammad, why do you think that the liraglutide failed?
First of all, because the ADA don't learn the lesson, at least from the first time. They need another study to learn. The Urixa study, if they remember, which was in 2007, in which Bayita was compared to sulfonylurea, they take exactly the same design. People who are failed on metformin, they randomized either to Bayita or twice daily Bayita or to sulfonylurea, and they followed people for 5 years. Exactly get the same results. Less failure with Bayita than with sulfonylurea, but still get about two-thirds of the patient failed after 5 years. Why they didn't, despite boosting the insulin? It's just because those drugs don't address well the insulin resistance. So they boost the insulin, but the door's still closed. The insulin is not getting in, it's not working. You need to open the door for the insulin in order to do the job. And this is why we picked this combination of the TZD plus GLP-1, because the TZD, the GLP-1 boosts the insulin up, but the TZD opened the door for that insulin in order to do the job. So if you don't open the door for the insulin, even though you can, it's like this woman, you are giving it the insulin from outside, 98 units of insulin. Even though she has plenty of insulin in her body, if the insulin is not working, still insulin resistant, you're not going to get well controlled, and you're not going to get maintenance in that control.
So Mohammed and I just sent a grant to the NIH to basically look at this. Why does GLP-1 alone not do the trick? So GLP-1 alone in one arm, pioglitazone, the insulin sensitizer, in the other arm, and then the two together. Remember, pioglitazone, and this is one of the big deficiencies we have. Pioglitazone improves insulin sensitivity about 40, 45%. But we don't have any other insulin sensitizing drugs directly. When you lose weight, it's an insulin sensitizing drug. But probably reversing lipotoxicity may be different than the way pioglitazone is working. So we do think that even though you're on a GLP-1 receptor agonist, and they're great drugs, you do need to activate the insulin signaling system so that the GLP-1 receptor agonist can really then work appropriately.
Okay, so the physician, and then at this stage, I saw the patient, measured the C-peptide, and the fasting C-peptide was 4.6, sorry, and after a challenge, it went up to 9.8 at 20 minutes after 2-hour glucose. So what would you do?
What was Mohammed's magic number? 1.7. Okay. 1.6 in another time, 1.8 mean is 1.7. And Mohammed, he likes to use 2, just a round number. So did we get a doubling of insulin secretion? Looks like a doubling to me.
Now, one more point I need to point out as a proof for the severity of insulin resistance for this patient. Look at the fasting C-peptide. What's the normal range, if you have normal range in your labs? It says, if it used nanogram per ml, it says 0.5 to 1.5, something like that. This woman has 4.6 fasting C-peptide. So C-peptide in the fasting state is not telling you about anything about the health of your beta cell. It tells you how severely insulin resistant you are. And this is a proof, the fasting C-peptide, how severely this woman was insulin resistant. So what then the obvious, what everybody would do now? Add pioglitazone. Exactly, because this woman is full of insulin, and the insulin is not working, and adding insulin from the outside is not going to solve the problem. Yes, and obviously SU and DPP-4 inhibitor is not going to do any benefit here.
What problem, if you just started the pioglitazone and you should start at a low dose, what problem might you expect, or a couple of problems with the pioglitazone even if you start at a low dose? More weight gain, yeah. Anything else? Maybe not at the beginning, but eventually, as the glucose comes down, have to worry about hypoglycemia. So,
Let's
you got some?
continue.
Yeah, Mohammed's got some more questions coming up.
Yes, we didn't finish. So based upon the C-peptide level, the physician decided to add pioglitazone to listen to your advice, and he added 45 milligram per day. And after 20 days, the patient is calling the doctor very urgently, complaining about 8.5 kilos weight gain and very severe hypoglycemia up to 40s and 50s. This is why.
If you fail this question, well,
So what happened here?
you have to leave.
We must stop pioglitazone here.
So before we say what happened, okay. So let's go to the vote, and then we'll come to the discussion.
Who wants number 1? All right. Who wants number 2? Number 3? Number 4?
Yeah. Okay, so before we go to what we do, let's start to understand what happened to the patient. So what happened to the patient? Anyone want to suggest? Yes, please. Exactly. So I already showed you or proved to you that this woman is overloaded with insulin more than even she needs. And the problem that her sugar was not going down because that insulin wasn't working. Once we fix the problem now she has overworking insulin. Okay? So the point is, and I agree with you, but the point is that when you start the PIO, unlike insulin, when you give the insulin now, you see the sugar tomorrow morning, the fasting is dropping. So what happens when you give PIO, the glucose starts to go down slowly. Now, what's surprising in this woman, and that's because she was so severely insulin resistant probably, is that the improvement in insulin sensitivity, or that little improvement in insulin sensitivity, because she was overloaded with insulin. So this is why she responded so strongly with the glucose.
May I ask,
Please.
why did you use 45, not lower?
Okay, so usually I use 30 as a rule of thumb, but you are right. Just for the case, I made it 45.
But I would just say start with 15. But eventually you're going to have to titrate up. And the other thing, remember that clearly now you sensitize to insulin, the glucose comes down. That means the glucose urea that was protecting the lady from gaining weight, now because the glucose goes down, the glucose urea goes away. Now that means more calories stay in the body. And then in addition, the pioglitazone stimulates your appetite a little bit. Insulin stimulates your appetite, so you're going to see the weight gain.
Yes.
She's eating more to treat the
treat the
hypos as well,
hypoglycemia.
he said.
Now, I made it 45 in order to emphasize any additional problem that people often are facing with starting pioglitazone, and because of that, they discontinue or not using pioglitazone. So the first one we discussed about the hypoglycemia. But what else happened to this patient? She gained how much? 5 kilos over how long? 2 weeks, 2-3 weeks. Is what type of that weight gain is? Mostly fluid, of course, because this cannot be fat. You cannot gain 8 kilos of unless you go crazy with food, right? But in general, this would tell us, and that's what I wanted to emphasize here, is that there was a lot of fluid retention in this woman in addition to the weight gain.
Now,
So,
just a couple of comments. There's 2 reasons why you gain fluid. Insulin works on the proximal tubules, studies we did a long time ago, to enhance sodium reabsorption. The pioglitazone sensitizes the proximal tubule to the effect of insulin. And so that's one reason. The second is pioglitazone is a powerful vasodilator. It releases nitric oxide. So you underperfuse your kidneys, and that sends a signal to your kidneys to hang on to the salt in water. So one of the things that would be very good when you're doing this kind of therapy is to make sure your patients have a scale at home. And you can tell the patients, if you gain more than 2 to 3 pounds in the first couple of days, just give me a call. Because sometimes the patients don't call you, like this patient, and they keep gaining the weight, whereas if they had called you because they had been warned about the weight gain, you may be able to see them, bring them in, and then readjust the pioglitazone and insulin doses before you get this kind of weight gain, be it fat or fluid. No, he says if you put them on 15 and they start to gain weight, does that mean you need to stop the pioglitazone? Well, if they gain the weight very quickly, in all likelihood, as Muhammad said, it's fluid retention. And now you have a number of options. One important one would be just add a diuretic. And, of course, you need to check and look to see if they're developing peripheral edema. But in this lady, my guess is you might actually see, with this kind of weight loss gain, you might actually see peripheral edema. But you don't have to stop the pioglitazone here. You just have to make sure that first you have to warn them, stop eating, because it stimulates your appetite. Reinforce that, and then you need to put them on a diuretic.
So the fact that this one gained so much weight and fluid that tells that the PPR gamma activation in her body was very strong. So not only she is loaded with insulin and we need to cut down on insulin, that tells us we overactivated the PPR gamma, and therefore we also need to cut down the dose of pioglitazone. Now, to your answer, even if I start in 15 and there is a strong response, it's still the same thing. That tells us even the 15 in that particular patient is overactivating the PPR gamma. So what I personally do, and there are no studies, just from clinical practice, I just give him the 15 every other day. And just keep cutting down in the dose. And I can remember now a couple of patients who take the 15 once a week together with a GLP-1 agonist, and their A1C is down back to normal, and they're very happy, and they're not gaining neither weight nor fluid.
We did the dose response curve. It's published 2001 in Diabetes Care. 7.5 milligrams means you have to split the tablet. The problem is it's not a tablet scored to split. So you have to have a pill cutter. But 7.5, you get a significant insulin sensitizing effect, no beta cell effect. At 15, a good insulin sensitizing, a little beta cell effect. At 30, most of the insulin sensitizing effect and a good beta cell effect. So you can start in an even lower dose, although it doesn't come as a 7.5 milligram tablet.
Yeah, another point here is you look into the response of each patient individually. So what Dr. Defonso is mentioning is about the mean. When you take, 20 patients, what the mean response would be. But that doesn't mean that every patient is going to respond exactly that mean. So here, the amount and the magnitude of fluid retention and the weight gain, that gives you an indication on how much you benefit from the you need, that patient is needing. And the hypoglycemia, of course, that tells you about the insulin. Okay, so the patient had, let's continue, +4 pitting edema in both legs. So physician reduced the pioglitazone dose to 15 milligram per day and the glargine to 40 units per day. Remember, she was in 98. And asked patient to monitor her fasting plasma glucose and then to report in 2 weeks. After 2 weeks, the patient has lost 9 kilos, still has pitting edema +2 in both legs, and her fasting glucose improved a little bit, but still around 65 or 75. What would you do now? Would you stop pioglitazone, keep decreasing the glargine, or stop pioglitazone and decreasing the insulin dose?
Who wants choice number 1?
Stop pioglitazone is choice number 1.
Choice number 1 is stop pioglitazone.
So nobody wants.
Choice number 2. And choice number 3.
Good.
Okay, so again, emphasizing what we just said. In 2 weeks, this woman lost 9 kilos. That's a huge amount of weight loss for 2 weeks. But why did that happen? Because she lost the fluid. Most of the fluid that was rapidly gained, but she lost some, but still has. Now, the other thing is the weight loss here, not only because you will reduce the pioglitazone dose, but we also cut down on the insulin dose. Remember, reducing insulin also will reduce the weight. So the physician decided to reduce the insulin dose and maintaining pioglitazone at 15 milligrams. And after 2 months, the patient has lost additional 4 kilos. She was on 16 units glargine, fasting glucose around 80, A1C 6.1, and no hypoglycemia. But still pitting edema +1 that the patient is complaining about. So,
Choices.
vote.
Number 1, stop pioglitazone. Who wants that choice? Number 2, add the GLP-1 receptor agonist. Number 3, add aldactone. And number 4, add furosemide. No one wants to act.
No, I would have added the furosemide earlier, okay? So if you want to add it here, I think is up to you. So you like the glucose A1C control. Pretty good. But the person's still on insulin, right?
Yeah, but the fasting's still 80. Right. Yes. So adding aldactone here or adding diuretics, that's exactly what we were discussing before. That's one way to handle the edema or the fluid retention that is caused by pioglitazone, and preferably if you use distal distal working diuretics, that would be beneficial for edema that is caused by pioglitazone. I personally give aldactone.
Yeah, so Mohammed, we did studies a long time ago, and Mohammed just mentioned that these people respond better to distally acting diuretics than they do to furosemide. Although it's contrary to what we think, the furosemide in not this group of patients, other types of patients is more potent. But in response to pioglitazone, they respond specifically because there's a gene in the collecting duct that is involved in sodium reabsorption that gets upregulated by pioglitazone, and that gene is in that transporter is blocked by the aldactone.
Plus, there's the renal benefit in the aldactone, right? So it would be a win-win.
There's also a renal benefit. We're not worried about heart failure in this person, but there would also be a potential, cardiac benefit. But there is, as you said, the renal benefit. So I think the real thing is we're trying to decide, should we add a GLP-1 receptor agonist in this person? And do you think you can get the person off of the insulin completely? Who thinks you could get the person off of the insulin completely? Put your hands up. I'd say 10% of the people. Who thinks you can't get the person off of the insulin? One hand. How many people are afraid to put their hands up?
Okay, so the physician has added dulaglutide 0.75 plus aldactone, discontinued the insulin. 3 months later, the edema has resolved, fasting around 100, and look at the A1C 5.8 with no hypoglycemia. And patient lost additional 6 kilos. So if now we repeat the C-peptide measurement, this is just academic questions, what would you think the result would be? Remain at 4.6 and 9.8 as it was before. Increase to 5.8 because now we have dulaglutide on board and GLP-1 at fasting, and then 15 at 2 hours. Decrease in the fasting and remains at 6, or decrease in the fasting and increase at the 2 hour. Remain the same. Let's vote.
Number 1. Number 2. Number 3. And number 4.
So it's a mixed. I didn't show. Okay, so let's start one by one. What do you think is going to happen to the fasting C-peptide? It's going to go up, down, no change?
Down.
Down. Why? Because we improved insulin sensitivity. So the choice is between 3 and 4.
And glucose went down.
Mm-hmm.
So there are 2 reasons. You improved insulin sensitivity in the fasting glucose, less of a stimulus. So the fasting is going to go down for sure.
So what's going to happen to the 2 hour, to the evoked or stimulated C-peptide? It's going to go up, down, no change. Why down? Why up? Why no change? Right. But on the other hand, what do we have now on board?
GLP-1
We have
agonists
GLP-1, which
prolong the life of
which is going to markedly increase. So I didn't show you this, but this is the OGTT, the C-peptide result from the Qatar study in people receiving insulin or combination therapy on the left. You can see the closed circles. Those are the OGTT at baseline, the response at the baseline. And the open circle, this is what happened to the C-peptide at 3 years. So look what happens to the fasting. The open circle went below the black circle, the closed circle. That's the fasting C-peptide. It decreased. But what happened to the excursion afterwards? There was marked increase in the insulin secretion, and that's because of the GLP-1 receptor agonist, even though the plasma glucose, the excursion under the plasma glucose went down markedly. So that was my case. I think it clarified some of the points. If anybody has any question or comments, or Dr. Franzo.
Yeah, so again, it comes back to the fact that if you understand the pathophysiology, there's a lot of insulin resistance. The hyperinsulinemia that you get from driving the patient with insulin is not going to correct the insulin resistance. And insulin has no direct effect to improve beta cell function. And if I can get you to lose weight, get rid of the glucotoxicity, get rid of the lipotoxicity, and I do it by giving you a drug that has intrinsic effects on the beta cell, you'll improve beta cell function. So this is a very good combination, and because you won't have to markedly increase the dose of pioglitazone, the cosmetic issue that goes with weight gain, you'll avoid. No one wants to gain weight. You know, we all want to look beautiful. Guys want to look handsome. Ladies all want to look beautiful. And if you gain weight, that's a real negative. But remember, that's a cosmetic issue. And for all of the things that Mohammed and I tried to take you through, there are ways of preventing the weight gain, specifically using it with the GLP-1 receptor agonist, a great combination.
So my take-home message for you from this case is always think about the patient, treat the patient, treat diabetes, not blood sugar, not where the A1C is. Think what's happening in the patient, whether he is insulin resistant, whether he's deficient, does he have enough insulin? Doesn't he have enough insulin? Why his sugar is not going down? When you think about what caused his blood sugar to go up and treat that cause, then you're going to be much more successful in not only achieving the treatment goal, but also achieving it safely and in a way that improve also other metabolic parameters.
Any questions?
And Mohammed and I, if there are no questions, we'll be around for a little while, because I know people tend to be a little frightened to ask in public. So you can come up and ask us individually afterwards.
We appreciate it. This was a very helpful session. Thank you very much.
Okay.